it's all semantics as far as what we want people to do. And to think about that separation of illness and identity of the illness, I think is really important. We had this conversation with an athlete about their sport, but I'm only a hockey player. I'm like, hockey is what you play. It is not who you are. It is what you do. And you are so much more than the activity in which you do 4 times a week, 5 times a week. And that separation, I think, is important.
Thank you for subscribing to the Frequency Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn and Kim Pittis.
Hi.
Hi. I missed you.
I missed you. It's like, how does 3 weeks? It's only been 3 weeks, right?
I think so. I was counting the other day. We got to have a sneak chat on the weekend, which got me through. It got me through into today. But This podcast is one of those things where I am so excited to do it every week.
Yeah.
And it's never like a job. I was listening to another podcast about life and work and fulfillment and people who were in these dead end jobs and hated going to work. And I thought, wow, how grateful I am to love everything that I'm doing right now.
And I was talking to somebody about, I'm looking for my other pair of glasses so I don't have the big silver rims on, and that is just not happening. I have a job. I have 3 jobs. And he said, what do you do for fun? I'm having a conversation with somebody and he said, what do you do for fun? And I treat patients and I go to work. Anyway, that's the most, what can you do that is more fun than that? So there were 2 patients yesterday, like brother from another mother, and they are brothers. One of them has Parkinson's and he walks in, he's had it for 2 years, right hand, trembling, shuffling, gait, stiff body, but he can, if he thinks, he can smile and he can make his eyebrows go and he do all that stuff. So the muscles move, but they don't move on purpose unless he thinks about it.
Okay.
And at the end of the first session, the tremor was down by half.
Wow.
He refuses, he hasn't taken any meds yet. And his basal ganglia was so compromised, is a good word, that said that I couldn't run 81 and 988. I couldn't run increased secretions in the basal ganglia. The tremor doubled. It's, okay, I'll back off. We'll do the pathologies first. We'll do it right. I ran 81 and 10. And he got up and the tremor was 30% less. And he felt good. It was good. His low back pain went away. Second day, I said, I didn't notice that you came in with pain at the 7, so let's just fix your psoas. So I fixed his psoas, and he played saxophone, so he learned how to breathe out of his belly. No, your ribs are supposed to move. So we did the ribs. And then we did Parkinson's again, only this time I listened better. And his profession was painting artificial eyes. So grinding the plastic, using, do you know brown eyes are mostly purple?
No.
And blue eyes are mostly yellow? Who knew? Anyway, so when he got up off the table, there was 0 tremor. And I had one machine on the second day, increased secretions in the basal ganglia ran for 45 minutes. And the tremor got less and less. And then I ran, you know that solfeggio thing for repairing DNA? I ran that on his basal ganglia while I treated his brother's neck across the hall, because that's the other miracle. Anyway, so he gets up off the table, tremor's completely gone. And I said, okay, walk. And he's still doing the flat-footed thing. And I said, no, I want you to heel strike, toe off, lift your toes, heel, down, toe, up, heel. He said, I have to think about it. I said, that's okay, think about it, but do it. His cortex was able to overcome whatever the basal ganglia didn't know how to do. That was really cool. So pretty soon he's walking completely normally. And once he starts walking, his arms start moving. The tremor starts, the tremor stops. How do you have more fun than that? Doing anything. That is, what do you do for fun? I go to work and I change people's lives. Thank you very much.
My response to how do you have more fun than that would be fly to Ireland and teach 30 people to do the same.
Exactly.
So we have so much to talk about with between Rome and Ireland and the patients that we've seen in between. But I want to talk a bit about Parkinson's because I've got about 3 Parkinsonian patients right now of variance, severity, and degrees. And I love hearing how you walked us through that because it's check. I've done these things. It's amazing to see tremors start and stop on command, right? You can see what irritates the tremor. You can see what calms the tremor down. And so when you can see something instantly, I think it's such a gift because so many times we have patients that don't feel the frequency. And then you have to explain that to them. You're not supposed to feel it. This is not a TENS machine. You're not going to feel a twitch. You're not going to feel it stimulating. But when they can see a tremor just stop and they're like, oh, wow, that feels good. Like, great. And then it starts again and they're like, wait, I'm like, okay, it's done now. Let's move on to something else.
And I made it worse by running increased secretions in the basal ganglia, and that's not supposed to happen.
Right.
So I learned something, and that's, we tell people in the core, every patient you treat will teach you something, and every patient that you treat will be different than the patient you treated that had exactly the same thing.
Yeah.
And so
and that's what we were talking about on the weekend. Like, that is for the professional students out there. I could just go to school for the rest of my life and I would be happier than anything. This modality is such a gift for the forward thinkers out there that are always wanting. We talked about the word mastery and trying to get to that point of mastery, but FSM has a way of never letting you get too complacent.
That's a great word. There is no complacency. Because every patient is a learning opportunity.
Yeah.
Oh, I have one. I have a patient with MS who's like severe MS, wheelchair. He has one hand that doesn't work much at all, blah, blah, blah. And one of the protocols on his custom care was bladder infection. I looked at his protocol and it was all 44 because most bladder infections are E. coli, and that's what I always use for bladder infections. And I said, wait a minute, where's your catheter? He said, it's in my abdomen. It's a suprapubic catheter. Goes to the skin. I said, I've been treating E. coli. There's no in your bladder. There's no E. coli on your skin. Your bladder infections are coming from improper hygiene around a suprapubic catheter. And he went, what? I said, did they tell you how to disinfect it every day? How to wash your hands before you touch it, before you change your clothes? How to put a merthiolate, bendectin, something around it on the skin before you put your underwear on, before you pull your pants up over it? Anybody ever tell you that? No. He's been on antibiotics for bladder infections, and the doctor cultures it, gives him the appropriate antibiotic. I said, what's the bacteria? I don't know. Our role as a coach for our patients is right there. The next time that you talk to your doctor, you ask him, what's the bacteria? And the doctor will say, you don't need to know because I'm just going to prescribe the antibiotic. Actually, you do need to know because no one has ever taught him. I had to look it up. How do you prevent bladder infections with suprapubic catheters? There's paragraphs of it. Nobody ever told him to do any of it. So that's the thing, because his bladder infections keep turning down his vagus, and his vagus down means his MS goes up. And he has gone through every immune suppressant.
Right.
And okay. Yeah.
That word complacency, right? Don't get complacent with any of the story that your patient tells you. And when I was in Ireland, just even talking about the concept of asking, why is this tight? Or why is this inhibited? And then you see that, like, that's a good face times 30. And they were like, but I'm like, no, but now you have to start thinking, why would this be tight? Why would this be inhibited? Don't just go with, you have weak glutes. And then you can see the
Don't
ideas.
just go with, I have impingement.
Right. And to your point, you would always say people would settle for that information because they would have no way of treating it otherwise.
Anyway.
Now we do.
Yeah.
But I want to go back a little bit before we spin all over the place.
Any place you want today. I just want to hear you talk.
Me too. But I just want to go back to Parkinson's for a little bit, because what I have found with all three of my patients is I can do a lot of great things in the clinic. It's getting it to last and to hold that I am really struggling with. So maybe you can give some more insight. Parkinson's is very, very tricky.
Yeah, no, the problem is it is progressive. For his Parkinson's, what happens is the basal ganglia start to die. And it's progressive. Whatever kills the first one kills the second one. Their next door neighbors, it dies and it says, well, you might as well die too. And they don't show symptoms until 80% of the basal ganglia is gone.
Wow.
You have the first resting tremor until 80% of the basal ganglia is gone.
Wow.
Wow. So it's usually associated with toxicity, but it can be associated with viruses.
Right.
So the other thing we did with this guy, now he and his brother were both there together. Patient said, I got vaccinated once, and oh yeah, I got COVID. Okay. Then his brother comes in while he's in the patient's in the bathroom, and his brother said he got vaccinated once, but he got COVID 3 times. Oh, okay.
Virus.
What does vagus do in the brain? It reduces inflammation, increases brain-derived nerve growth factor. It increases nitric oxide. It reduces inflammation, decreases glutamate, which is the stuff that kills cells. And so the first thing I did was treat his basal ganglia and his vagus and his capillaries. We spent the first hour treating him for long COVID, all by hand, because I didn't have it programmed in a custom care.
Right.
And then you get to think through it. Have you ever been exposed to pesticides? No. I worked on a golf course one time, but they said they didn't use, it was very ecologically friendly. They only use good pesticides. Aha. Okay, that's like using good arsenic versus bad arsenic.
Right.
So then we started treating for other kinds of toxicity. And because he made glass eyes or plastic eyes, we had to use some of the toxicity frequencies I never think of.
Right.
And then what else do we need to do? I gave him supplements for the mitochondria. He's already taking 2 or 3 of the 4. So now he's on that. And he is doing phenylalanine and the one that starts with a T. The jet lag's not too bad, but my brain's fine, but the words are someplace I'd say over New Jersey. They're not quite here yet. No, the words anyway. So he's taking one of the 2 supplements. He's taking the most important one that Bellica recommends to help support production of dopamine. And he's taking 2 of the 4 things that helps with mitochondrial detoxification.
Right.
Okay, I added CoQ10, this and that, and I said, and you need to take levodopa-carbidopa. You've been 2 years into this. If you'd started levodopa-carbidopa 2 years ago, you wouldn't be here. Now, your neurologist he said, he prescribed it, but I haven't taken it. It's a guy thing. And I said, they prescribe levodopa-carbidopa, but they don't prescribe a receptor agonist. And that is why Patrick Wood is coming to the advanced.
Right.
And you can take amantadine, which somehow is a dopamine receptor agonist, and it prevents influenza A. I'm not sure how that works. But anyway, so it's like the receptor has to be more receptive for whatever you can force levodopa-carbidopa to do. Then you can keep the dosage of levodopa-carbidopa low so you don't burn out the basal ganglia, because that's what happens, and you don't get side effects from levodopa-carbidopa like twitching, and it makes the receptor more sensitive. You're going to have to take pills. I want to do it with FSM and nutrients. No, just no. Oh, okay. Walk, use your custom care, take the levodopa-carbidopa that he prescribes and break it in half. Start low. Take the Mirapex, break it in half, start low, see what that does, how you feel. Oh, the information we give as FSM practitioners, because of what you know that nobody else knows,
Right.
which for me is hard to believe, but takes adult beverages, is empowering.
Yeah.
I can't fix this guy's MS.
Right.
But what's happened is, because of where we started 2 years ago, he's gotten to the place with his emotional growth and his spiritual recovery that I wanted him to get to 2 years ago, but it was too soon.
Right.
Had to wait. He had to recover from emotional trauma, abuse, crazy marriage, crazy parents, all of that. He's gotten to the place where he's happy. He goes to 5 Joe Dispenza workshops a year. His body doesn't work. And at Joe Dispenza's workshops, he stands up and he stands up, a little help, but he stands up someplace between 2 and 10 times in 2 hours. And he's happy. And the place I wanted him to get to, because his MS ain't going away, and I really hope he's not listening, his MS ain't going away, but the place he needs to get to is, it doesn't matter whether it goes away or not, because you are not your MS.
Right.
You are not your illness. You are not your pain.
Right.
And who else thinks that way?
I think it's really important. So you and I see very different demographics. However, I have seen some very complicated cases. Thank you, FSM, that have
You
wal-
asked.
waltzed in. And like what I say, people are like, I'm not an athlete, but, and I said, no, you are a person that moves. We are all athletes of varying degrees. And
Okay.
we talked about a squat. A squat could be something very complex with the barbell and weights, or it could be just lowering onto the toilet. The mechanism of action is exactly the same. It's all semantics as far as what we want people to do. And to think about that separation of illness and identity of the illness, I think is really important. We had this conversation with an athlete about their sport, but I'm only a hockey player. I'm like, hockey is what you play. It is not who you are. It is what you do. And you are so much more than the activity in which you do 4 times a week, 5 times a week. And that separation, I think, is important, whether it is that illness, that disease, that
Inconvenience.
inconvenient.
That's a good word.
Yeah. And we talk about this with pain patterns. What's your pain? It's a 9 out of 10. No, it's not. It's not. You drove here. We were laughing just 2 minutes ago. It's not a 9 out of 10.
You minded a 9.
And maybe that's that second question on the patient history now is what's your pain out of 10 and how much do you mind it? How irritating is the pain? Oh, and then it starts to.
How much does it scare you? Oh, speaking of what, okay, finish your sentence.
No, that was good. How much
Yep.
does it scare you? Because that is definitely part of the conversation. And I think this is where I really started seeing the magnitude of 40 and 89 was treating somebody who had PTSD from a car accident, who would have so much tropic change on the table, so much smush. And the minute before even getting up, the phrase was, this is going to hurt so much. The person didn't even rotate, just sitting on the table. This is going to hurt so much. I'm like, why is that the story that you're saying out loud? Like, how much does movement scare you? And so that was where I really saw the importance of running 40-89 with certain patients while you were doing a treatment before they got off the table and moved, because there was that fear. Yes.
Before you even tell them they're going to get off the table.
Yeah.
So the other patient I treated yesterday had his complaint, minimal pain. I fell off a bicycle. I hit it. He loves mountain biking, and he was on a rocky thing. And one of these innocent looking rocks was a tree stump. And so bike stop, he didn't, fell, hit his head. His complaint is ever since that accident a year ago, there's this whooshing sound in his ear. And he said, it's constant. I mean, it comes and goes, but it's constant. And I have this one chiropractor that adjusted my neck and it went away completely for 6 hours. And so I did the supine cervical practicum, and then I have to tell you what Eduardo did to my neck in Rome after the instructor practicum. The vagus nerve comes out just behind your ears, and it comes under your jaw and goes inside your skull and gives you tears and constricts your pupils and gives you saliva and that helps you move your tongue and all that. But the other thing it does is it goes in the back and it wraps itself around the blood vessels that go to the dura. I want everybody to think about that. The vagus nerve wraps around the blood vessel that goes to the meninges all around the skull. So Eduardo went to the back of my neck, which anyway, and he said, wow, that's really tight. And so I did, before you can get to the vagus and the dura, between the skull and C1, because we do between C1 and C2, when we do the RCP minor, we do that connection between the RCP minor and the dura, and we get that to move. Between the skull and C1, there's a space. So he did scarring in the nerves to allow him to get into that space. Then he did, I don't know how he does this, but he did, oh, that's connective tissue. So he did scarring in connective tissue. Then he did scarring in the dura, and then he did scarring in the vagus and scarring in the artery. And I was conscious while I was doing this. I was conscious as you ever are when Edward was working on you. And then I've had open heart surgery, and he found this rib at T4, not related to the discs in my neck, the rib at T4 that was just like, ow. And he said, oh, heck. So we went down below my, what is that, fifth rib, sixth rib? And left side was smushy, right side was hard and it hurt. I went, ow, what's that? And he said, well, that's your vagus. Shut up. No, it's your vagus. So he followed it all the way down my abdomen, scarring in the vagus. And he said, what happened to the right side of your abdomen? When I was 19, I had a ruptured ovarian cyst. And when I went in looking for a ruptured appendix, they found 2.5 pints. A pint is 2 cups. So that's a quart plus a cup. So that's 5 cups of blood in my belly because this ovary bled and didn't stop. So he followed the vagus down, and then he gets to the bladder. Now, you know where the ureter goes into the bladder? You know that the vagus goes into the bladder, and it's a pain nerve clear down to your pubic bone, and it crosses the ureter. And he peeled them apart. 13 on the vagus, 13 on the ureter, 13 on the bladder. Who in the world thinks like we do?
Right.
And of course he did his dura thing. And then he said, okay. So he sat me up, world stopped spinning, and they said, tip your head. You've known me for how many years? Have you ever seen my head move like this? And then he said, tip to the side. You've treated my body before. Have you ever seen my body move like this?
No.
And he got the rib to go back in by running scarring in the dura and scarring at the joint capsule where that rib got rocked, stuck hard, and then it just rolled to the rolled. Who thinks, it's not only who thinks like that, but who else can do that?
Right.
Besides there's 30 people, 29 people in person, but the 100 people that are going to listen to this podcast, or 200, however many find it on YouTube.
Right.
Who else thinks like that? Who else has a tool that lets them do that? Anyway, I was doing this torn and broken in the ligament, so the supine cervical practicum, because his atlas, his C1, was over maybe 3 millimeters, 4. Remember that picture on the core of the internal and the external, the vertebral artery goes up through the little hole, and then right next to C1, because we asked the question, why are these 3 muscles so tight to keep C1 centered? What makes it so important for C1 to stay where it belongs? And there is the internal and the external carotid artery right next to C1. And I said, tell me about the whooshing sound again. What's it sound like? He said, it's every time my heart beats. C1 and that picture from the core with the internal and the external carotid.
Right.
That's the whooshing sound. And I got it back centered. And I said, you are to take 1 baby aspirin every 3 days because the whoosh is pressure on either the, I don't know the anatomy, John would, internal or external carotid. That's the whoosh. Whoosh is turbulence. Turbulence means blood clots. The only place for a blood clot to go from the internal to the external carotid is up in your brain. You are to, number 1, don't do anything stupid again. That means you run on flatter trails. It means you take aspirin only every 3 days. And because I don't want to have, and you start using your CPAP again. I didn't think it made that much difference. You don't have to think it did. If your pulse goes up from 70 to 150 because you stop breathing for 5 or 10 seconds, that increases the pulse width in that artery. And C1 happens to be whooshing because of the way you're laying. I don't want to be treating you for a stroke for 2 years. That's your homework. And then as he was paying the bill, I said, I can't charge you that much. And he said, no, you charge me the full weight because there is not another person on the planet who could have figured out that. And it's only because of the picture that's in the course seminar.
That's that part of once you see it, you can't unsee it or you can't unhear it. And you and I were talking about cellulitis with that. And thanks to David Mesnick's pictures, they're burned in your brain and you just see it and you see the angriness of something like cellulitis, the emergency of it, that you go now.
Yeah. Now. Yep. There
Right
was
now.
Somebody sent me a picture in an email and said the patient fell, hit a rock. He's got this little scab. And I looked at it and went, I saw David. It wasn't red. There were no streaks. There was no thing that said this is cellulitis. And there was David Mesnick's pictures in my head.
Yeah.
Because that's what it looks like.
Right.
It's like a puffy scab.
Right.
And I went, that's cellulitis.
Yeah.
You call the patient right now and you send them to the emergency room.
Yeah. I think I was telling everybody when my daughter was in the hospital for 2 days on IV antibiotics because of her elbow bursitis turned into cellulitis literally overnight. And she woke up. I'm like, let me see your elbow. And I'm like, put your shoes on. She's like, can I eat my cereal? I'm like, nope. Put it in a bowl and we'll eat it in the car on the way to emergency. And when we went to urgent care, the cute little urgent care doctor looked at, he's like, okay. And he said, okay, about 17 times. I'm like, I know it's bad. And you need to go to emergency, not urgent care, emergency. I'm like, okay, you have 2 choices, this hospital or that one. And I'm going to call and let them know that you're coming. I'm like, okay. And when we finally got her into the pediatric ER, one of the doctors was like, how did you know already to bring her? Because we typically don't see it when it's this small, but way easier. And she still needed to be in the hospital for 2 days on IV antibiotics. It still wasn't just take these, here's a prescription, go home. It was bad. And then you have that moment of thank goodness for those pictures. Thank goodness for all this training that I would have never had access to without FSM. And so just when you think why I'll go back to when we used to have 2 tracks at the advanced, and I walked into Mary Ellen Chalmers's failed root canal talk. And a part of me was like, why do I need to hear about dentistry? But that voice inside of you is go sit down and listen. And thank goodness, because 4 months later, somebody had a dental infection in the clinic that I wouldn't have put those pieces together without hearing all this information. So it's never outside of your scope to get the information. It's information, it's knowledge, and what you do with it can make all the difference.
And there's no, we can't call it ART, but there's no pin and stretch myofascial therapy, trigger point therapy, manual therapy workshop ever anywhere that does what we do for our family, our colleagues, our
Right.
like-minded collective. I don't even know what you call the FSM family, but they're people that are not complacent.
Yep.
They're people that, with any luck, once they see it, they don't ever unsee it.
Yep.
In my perfect world, everybody we train, my big problem is I never get to David Mesnick's slides, except I do stop when I get to cellulitis. I never get to make David Mesnick slides on Sunday because we're always so far behind doing the physical medicine stuff.
Right.
And I can't bring myself to make the core 6 days. And so we just have to figure that part out. But it's the mindset. It's how we think. And that's, everybody knows, thank you for, who was it? And she was in the second row on the right and said, can we have a 4-day advanced? She has no idea what's coming because everybody thinks it's going to be the same things and they're just going to be more tissues, because that's all I skip is the tissues. The first day in 2 hours, I do, how do you think about Alzheimer's? What is the process? What is plaque? What happens? What kills the cell? And then it isn't the plaque that kills the cell, because people die of Alzheimer's that don't have a lot of plaque. So we do the how to think about it in the first day and a half, morning and a half, because nobody needs to listen to me for 2 full days. So then we have the second day, and I get through the miasms, and then everybody thinks, just for everybody that's listening and might listen, everybody thinks it's just going to be the rest of the tissues. And I hate to tell you, but the next 2 days, the next 2 mornings are going to be more of how do you think about it? The vertebral segments that I never use, Ben Catholi does magic. Now, Ben can't come, but I'm going to be on the phone with him between now and March. And there's frequency for the tubules in the kidney. There's frequency for the kidney, but there's also frequency for the tubules. So you have to think about what the kidney looks like inside and what goes wrong with it. What exactly goes wrong with it? And it's all capillaries. The most important thing about the kidney is the capillaries. Everybody thinks the kidney is the kidney and the urine filtering and the tubules, but the most important thing about the kidney is capules,
right?
Capillaries. And then there's long COVID. Patients that had COVID, this is back in 2020, patients that had COVID were coming in kidney failure. Now, the ventilators made good television.
Right.
Respiratory, being unable to breathe is what killed people. But they came in with elevated liver enzymes and low GFRs, and they were in kidney failure. That doesn't have anything to do with your lungs except for the capillaries.
Right.
So everybody that thinks we actually had questions about, I've been to the advance twice. Can I just come to the last 2 days? It's, oh, honey. No. Anyway, you should keep talking because I'm on a roll here.
No, we have a whole bunch of questions too. So we'll just
Okay.
talk about some questions. First one, how can FSM address hyperthyroid function?
We can't.
Okay.
Oh, hyper, yes, yes. It's just 40 and the thyroid. And it's hyperthyroid because that's the first stage of, it's an autoimmune condition where the antibodies attack the thyroid, make it inflamed, and make it produce too much thyroid. Okay. Antibodies. What are antibodies? The interesting thing about being hyperthyroid is most MDs don't check antibodies. And then every FSM practitioner that is listening should be saying, what does the vagus nerve do to the immune system? Suppresses T cells and macrophages. Hyperthyroidism caused by antibodies is an autoimmune condition created by T cells attacking the thyroid and creating inflammation and make it produce too much thyroid until it burns out, and then you're hypothyroid because all your thyroid producing cells died. Okay, so what do? Treating the thyroid to get your pulse down and make you stop being flushed and hyperventilate, that's easy. That's just 40 and 98. That's not hard. But how do you think about it?
Mhm.
I have to turn the vagus on. Then the next question is, what turned the vagus off? When did this start? And what happened 1 to 6 months before? Who asked that besides us? There's nobody that asked that because they're just given a pill or an immune suppressant.
Yep.
And then they wait for the thyroid to burn out. And then there's that.
Yeah.
So it's, yes, that's,
Okay.
It's not that hard.
All right, next one. Are there a collection of frequencies that will help trigger finger? Had a few clients and it seems to be a hit and miss. One case of trigger finger with Ehlers-Danlos experienced slight swelling and worsening of her condition after second protocol, which she did while squeezing on a ball unbeknownst to me. Running soft tissue injury, lymphedema, torn and broken and connective tissue, inflammation in the cord. Nothing has improved the situation. Suggestions. She will be driving and will be unable to provide any additional information.
Okay, so here's the deal. I have trigger finger. You see this finger that doesn't straighten out? That one. This everybody knows is C7. It's anything else you want to call it is up to you, but that's C7. And I have 5, 6, and 6, 7 fused because the herniated disc pressing on my spinal cord. And then because it was fused in 2010, so 15 years ago, no, yeah, there's bone spurs there. And because I have stiff person syndrome, number one, the C7 nerve root is irritated. And if you feel this muscle right here, one of the finger flexors, it's tight as a tick, right? G-string. And so it's all really tight. And I had my GP inject this with steroids when we got rid of the bump. But that's not the problem. It stayed good for about 2 years, but that's not the problem. I can get rid of this. I did 217 and 13. It's scarring because there's a connective tissue lever that gives, to see how that finger has to have a lever to bend across. There's a big knot, and I'm 79, so that knot is made out of 217, not 91, and it's scarred. What's it scarred to? There's a nerve, and there's a tendon, a round tendon by the time it gets here. So it's 77, it's 191, and it's 396. Is that enough? No, because the knot is not the problem. The C7 nerve root and my neck being compressed by the little bone spurs, the words actually maybe have reached Oklahoma. So the bone spurs make the nerve irritated. And I got the same thing on the other side, but it's not as bad.
Yeah.
But this one catches.
Right.
And same problem. And now the only guy on the planet that I trust to inject them has retired. And okay, fine. So I have to fix it myself. But it's a 3-step process.
Right.
It's do your exercises, stupid. It's that part to get rid of the bone spurs, Oklahoma, bone spurs. And then I can run nerve pain alternating at night to quiet down the nerve that makes C7 tight.
Yeah.
And then I treat my vagus to treat the immune system. And then one of these days, I need to get in here and get the hardening and scarring out of the connective tissue, the nerve, and the round tendon.
Right.
So MDs do what John did. He injected steroids here, and it lasted about a year.
Right.
To treat it and have either any effect by the time it's this bad and you're my age, you have to treat here, and you have to think of it as a where did it start? What causes it? For God's sakes, take a baclofen in the morning.
Sure.
Just because I walk with fluid motion and my lower muscles aren't spastic doesn't mean that this isn't tighter than it should be.
Right.
When did it start? What causes it?
Yeah.
It's
thinking of not just myopically, it's thinking of more than just
the process.
And I think that's the biggest challenge.
Yeah. So the EDS patient, check her knee reflexes and tell me whether or not she has a 6-7 disc. Do a sensory exam. Tell me whether or not the C7 nerve root is irritated.
Yeah.
She is hypermobile. She should not have a trigger finger. She does. Then you have to figure out why. I'm sorry I can't make that easier, but
no, that's perfect.
You have to think.
Going on to thinking.
Yeah.
The question is about toxic mold. How can FSM support healing from toxic mold in addition to getting it remediated? There's a mold sinus program on the custom care. How does it work? Anything else that can help?
So here's the thing. Tyrosine, thanks, Leaf, and arginine
for kidneys.
Vasodilate the kidneys. Thank you. I just love the whole Erickson family. Anyway, here's the thing. FSM frequencies are not high enough to kill biological organisms. And so, no, FSM doesn't kill mold.
Right.
And remediating it in the house, I mean, Richie Shoemaker deserves credit for starting this whole area of awareness of mold. But remediating the house just doesn't make any sense. It's kind of like rearranging the deck chairs on the Titanic. You have to remediate the mold that has colonized the patient. And there's two pieces of it. One is mold in the sinuses, and all FSM can change is cell signaling.
Right.
You got two little things, and we use the key fob, and the receptors go like this and stuff like that, and that's what we can do.
Right.
So, and infection, the vagus is turned down, it's never off, turned down by infection, stress, and trauma. So they all have digestive problems, because I'm tight dog. All have digestive problems. They all have brain fog. They all have sinus infections because of the Marcons. And so you need to be on antibiotics for Marcons. I don't want to hear it. It's tough. I don't care if you don't like antibiotics. I don't care about your microbiome. I really don't. I don't care. You have to take antibiotics and use this really obnoxious nasal spray to kill the Marcons. And then you have to take antifungals. Shoemaker doesn't like antifungals. Neil Nathan does. Neil Nathan saved my life, so we're going with the Neil Nathan program. And you have to get rid of the mold that has colonized your sinuses, your bronchi, your digestive system, and turned your vagus down. The vagus is turned down by infection, stress, and trauma. Infection, stress, and trauma. Yeah, so you can use mold in the sinus, mold in the gut, mold in the vagus, mold in the bronchi. For me, it gave me primary pancreatic failure for 5 years.
Wow.
I didn't make any enzymes. That was black mold. That's neurotoxic, should have affected my brain, made me anxious, a little bit depressed, but mostly I didn't make enzymes. That was the thing. And FSM wasn't enough to do any of what I needed. I needed the nasal spray, I needed the antifungals, and I was on antibiotics for Marcon's and the jaw infection for 6 years. 6 years. And yeah, and then I was on antifungals, one antifungal for the mold that had colonized my gut, but a different antifungal for the thrush I got in my mouth from being on the antibiotics or my sinuses.
Right.
So I don't like to take pills. Okay, then be sick. I don't sound very sympathetic, do I? No,
No, but I think we've always been very clear, whether it was something systemic, pathological, or straight up muscle, it's an adjunct. Next question, and we have to hurry. We're almost out of time. Patient with arterial aneurysm, dissections, and carotid arteries using FSM as an adjunct. What protocols would you recommend?
Postoperative tomorrow. Postoperative are protocols. 124 and the artery until you can get the patient to a vascular surgeon that'll fix these. And then you treat them postoperatively. This is surgical, quickly surgical. Dissecting the carotids is bad. Look it up. It's really nice. Google searches.
Kate, you're so right. That's what I love. That's what frequency specific to each body. It's not textbook. It doesn't put everyone in a box, and we get to be Sherlock Holmes every day. You couldn't be more.
I want everybody to know that Kate Adams is the reason that we do 13 and 60.
Wow.
I had a kidney infection when I was 22, and I had a kidney infection when I was 22, and everybody had been telling me to stretch my psoas and do this to my psoas and since I was 25 or 26. And the psoas being tight helped grind away the cartilage on the top of my right femur. So I needed my hip replaced when I was 57. Bad. And Kate was working on my psoas, and she said, that doesn't feel right. What she said was the magic question. I wonder. And then she's pressing on it, hurts like crazy, and all of a sudden it gets warm. It gets soft, and my whole pelvis goes from this to that. What did you just do? Oh, your ureter was scarred down to your psoas. How'd you figure that out? That's the only thing it could have been. Oh, okay.
I love it. Good job, Kate. Sherlock,
Thank
Kate.
you, Kate.
And then Lee finally asks, do you still like meclizine for sleep?
No. Meclizine for sleep is good for people with meclizine. Jet lag really does things to.
You're doing great.
Okay,
I'm so proud of us.
Meclizine helps when you have a vestibular injury only.
Right.
That's the only time it helps. And what I have used for sleep over the years, and you're talking to somebody that changed time zones twice a month for 18 years. Every time, no, longer than that. But anyway, you can use anything you need for sleep. In the past, I have used meclizine when I got Meniers. That helped. I used Benadryl. I use Ambien. I've been on Ambien since 2000. and I'm still on it, doesn't bother me. I use melatonin. This is a Musnick thing. Again, I don't know where he picked it up, but topical melatonin. There is a paper on it that supports the use of 100 milligrams of melatonin topical, and DMSO, the stuff that gives you this, I can taste it, and emu oil and DMSO, and he has me on 250 milligrams because I have an autoimmune thing. And then when I still had trouble sleeping, they added Rameltion. It is an melatonin receptor agonist, right? So the most important thing, Leaf, is to sleep. So patient said, I toss and turn all night. You have sleep apnea. I don't snore. I don't care. You don't toss and turn all night unless you have really bum shoulders, bum hips, or you have sleep apnea. I had this sleep study and it said I had sleep apnea, and I used a CPAP and it didn't make any difference. So I stopped using it. And it's like, you have sleep apnea. You use your sleep apnea, or it is what will kill you.
Right.
So that's whatever it takes.
Yeah.
Some people can take 3 milligrams of melatonin orally and Rameltion orally. When we use the Vegas protocol on people, we also use Huperzine A because it is a supplement now instead of a prescription. It's a supplement that is a receptor agonist, and it's an acetylcholinesterase antagonist. So it is an antagonist to the enzyme that takes acetylcholine apart in the synapse, Oklahoma synapse, where the vagus uses acetylcholine to inform the receptor that the vagus is working.
Right.
There's a enzyme in there that takes apart the acetylcholine, because you don't want the acetylcholine hanging around too much or you're going to be spastic.
Right.
So you want acetylcholinesterase, the enzyme that takes it apart, inhibitor, to make that enzyme not work quite as fast.
Right.
So you take Huperzine A and you're on the Vegas protocol.
Right.
You do both. And we can do that. It's a supplement.
Yep.
And we got data. We have a patent that says the Vegas protocol works.
Right.
Thank you, Jennifer Ernst.
So exciting.
I want you to talk more.
But we're out of time. So I will talk more. I'll talk more.
People listen to a podcast that's 2 hours long just because we want to do one.
I don't know. Maybe.
Well,
They can always, if they get tired of us, that's the power of podcasts. You can always stop it and pick it up later when you want. So maybe we do a special one day, a 2-hour special.
we'll ask Kevin.
Yeah.
Oh, wait, Denise Lassiter said yes. Yes.
Everybody says yes. The dog is barking. Everybody's happy. So
Everybody said yes. 2 of them says yay, yes.
Yeah.
They're probably the same 2 people that wanted a 4-day advance.
maybe.
Yeah. Oh, and the John Sharkey's coming. I don't want to make you nervous, but John Sharkey is going to lecture on Thursday or Friday because he's coming to your Wednesday workshop. Inhale, exhale, breathe. Yes, there you go. You're doing fine.
Sorry, the dogs are barking, but that makes me that doesn't make me nervous. That actually makes me so excited because I'm at that point with the course. I'm so proud of it. And I love to share it and get the feedback from all the brilliant minds and how to keep making it better and better. And that's the way we grow.
Oh, we need to talk about the next time. We'll put tape over my mouth. I'll give it to Kevin and just go like that. Because you need to talk about what you're going to do with the sports, because I am so excited about it. It's just brilliant, necessary, and it's not sports. It's FSM rehab, because that's the next step. Just learning the frequent. Kate Adams says do it, and Lisa says thank you, because that's the next step. Learning the frequencies, learning how to do stuff. How do you teach somebody to rehab the throat? Or sure, you take the subscapal part. Yes, you do this, but then what? How do you do that without teaching them to activate the serratus and the lower trap?
Yeah, it's just so much fun that there's that look on their face when they're like, wait a minute, there's more to the story. It doesn't end here. No.
Oh no.
There's a whole other world of movement that is just so exciting. So yay.
Yay.
But really, that's it. That's it for today, everybody. We're over, but we started late, so it's all good. And we will be here next week. Yes. Okay, that's it. So we'll see everybody same time, same place next week.
See you next week.
Bye, everybody.
Do good things, save lives.
Yeah.
Change lives.
Change lives and save lives.
And change the world, according to Jim Oshman. There you go.
No big deal.
Bye.